And with that, I'd like to introduce to you Dr. James Whitworth, our guest speaker for today. He obtained his medical degree from the University of Leicester in 2007, and then completed his PhD in 2019. He also completed an NIHR, which is a National Institute for Health Research in the UK. He completed an academic clinical fellowship in clinical genetics, and then he was later appointed as the NIHR academic clinical lecturer and university lecturer honorary consultant in medical genetics. He is currently a clinical research fellow in the Department of Medical Genetics at the University of Cambridge. And as some of you may know, his research focuses on identification and management of individuals at increased risk for developing tumors and cancers.
Well, first of all, thank you for getting the pronunciation of Leicester right, which isn't always easy. And second of all, thank you for asking me to give this short talk on this interest that of mine and the department's that's developed over the last few years, and that's of multiple primary tumors, but particularly in the context of inherited cancer predisposition. Inherited cancer predisposition, I guess, is the reason we're at this meeting, and one thing we're used to doing is considering what are the clinical indicators of that situation. Some of them are quite specific, like a high-grade serous ovarian cancer, for example, or particular aspects of the histology. But we're also used to thinking about general indicators of predisposition, and those are things like a young age at diagnosis and an extensive family history. But also the occurrence of multiple primary tumors. Now, the definition of multiple primary tumors, or at least the assessment of it, isn't always that straightforward because of the possibility of recurrence or multicentric malignancies. But there are guidelines to help, and we've tended to gravitate towards the International Agency for Research on Cancer guidelines to really define those lesions that are genuinely histologically distinct and represent different clones. This is not an especially uncommon phenomenon, particularly given that cancer survivorship has increased, and there's a number of studies that show a really appreciable rate of cancers that occur are part of a multiple primary phenotype. This one from European registries, about 6%. You often see similar figures in other studies. The seminal one, which I haven't put down here, was one in Connecticut in the mid to late part of the 20th century. And those papers not only report that it's quite common, but also the fact that if you have one cancer, then the probability of another one increases. And there could be a number of explanations for that. It could be down to chance. It could be down to shared environmental factors, including treatment for the previous cancer. But it could be down to constitutional genetic predisposition, and that's what we were really interested in. So with that in mind, we expected a multiple primary, and I'll refer to it as MPT from now on, cohort to be enriched for predisposing factors to developing cancer, or predisposing genetic factors. And so we assembled this series of individuals, and we defined MPT as 2 primaries under 60 or 3 under 70. And these were all ascertained through clinical genetic services, predominantly in the UK. And they had all had pre-assessment and testing. So if they'd had, say, a BRCA1 mutation identified, then they wouldn't be included in the study. And they underwent whole genome sequencing as part of this larger project funded by the National Institute of Health Research in the UK, the Bioresource Project, which sequenced about 10,000 individuals of varying disease phenotypes. And our aims with this were multifold. It was partly to look for novel cancer predisposition genes. I'm not really going to talk about that side of things today, but we were also looking at a known list or known cancer predisposition genes, and we curated a list of 83 that were based on the current knowledge, current literature, and those are consistent with an adult presentation. We filtered those variants and assessed them with ACMG criteria as we could, as they were interpreted at the time. There's been a few changes since then. And the aims there were really to see whether there was any evidence of phenotypic expansion here. So unexpected variants that were indicated, that were seen in people with atypical phenotypes. Whether this general indicator of MPT could help us guide testing prioritization, and also whether there was added value in using whole genome sequencing as compared to a gene panel, for example, because this is essentially a virtual gene panel, but with whole genome sequencing. And this just describes who this series was, or at least in terms of who has had the whole genome sequencing so far. And so there are 454 probands included here, predominantly female, and a vast majority European ancestry as assessed by analysis of SNPs. And when you put those people together, there are obviously lots of different tumor types, 91, and then you start combining them up, and there are lots of different combination types here, 330 in all. So it's quite a heterogeneous series. You can see there that the most common tumors essentially reflect the common things that are referred to clinical genetics, at least in our services in the UK, breast cancer being very much the most common, and only colorectal, kidney, ovarian and endometrial making up more than 5% of the total. And that diagram on the right really shows how heterogeneous this group was, and how there isn't a particular combination that's very dominant in this group. So when we analysed single nucleotide variants in indels here, the ones that we assessed as pathogenic or likely pathogenic occurred in about 14% of our probands. Remember, these had already been tested and assessed by clinical genetics previously. And each of these genes really tells its own story. Some of them are genes that weren't previously tested when the patient was originally referred to clinical genetics, so PALB2 would be an example of that. CHEK2 and ATM still not routinely tested. Some of them probably represent individuals that fall outside of the clinical criteria for testing. So that likely explains many of the BRCA2 variants that were found. And some of them represent really atypical phenotypes, so individuals that wouldn't have had the relevant gene tested for because they don't have a tumor that was suggestive of having a variant in that gene. The NF1 ones, interestingly, that they all had typical manifestations of NF1, but that's not typically tested for in UK genetics practice, so that might explain some of those. But one of the interesting things and one of the potential advantages of whole genome sequencing, even if you're only looking at particular known genes in a virtual panel setting, is that you can look for structural variation. And that's because the more uniform coverage and of whole genome sequencing, you can assess more easily which areas of the genome have a higher or lower copy number. And it also increases the chance of sequencing across breakpoints that can indicate structural variation. We found 7 of them, and the reliability of the variant calling, which is done by these algorithms, Canvas and Manta, isn't necessarily 100% far from it. We did validate the breakpoints with these, but we're more sure about some of them than others. So the top few is where there's a bit more evidence that they may be real and causing a phenotype. Two of them involved folliculin, 1FH and 1P10. But the others at the bottom may well represent more complex structural variants that appear to affect the gene in question, but in reality don't. For example, the TSC2 one at the bottom is recurrent, and there's a group in Vancouver who've looked at this sort of thing and found that's not actually an inversion, and it's part of a more complex variant involving a different gene. And we're validating these at the moment with nanopore sequencing to try and get a better idea of whether they're real or not. And this just is a couple of pedigrees and plots relating to a couple of those structural variant calls. So this is an inversion involving P10 in a family with a strong breast cancer history. So perhaps more likely to be significant, although interestingly, one of the individuals with breast cancer and mucinous ovarian cancer didn't carry this P10 inversion. And the other one was the folliculin translocation, and that was in a family with a very typical phenotype, and that hadn't been detected by clinical testing previously. So if we combine those single nucleotide variants and indels and structural variants, we can see that about 15% of these pre-tested individuals had a variant assessed as pathogenic or likely pathogenic. It doesn't mean it was necessarily diagnostic of their of the cancers that they had, but it would be something that would usually prompt further genetic counselling. We were aware that all of those easy diagnoses, if you like, of typical cancer predisposition syndromes may have already been made in this particular series. And so we considered it in the context of a previous multiple primary series that we looked at that weren't pre-tested, where we found a roughly 20% diagnostic rate in there. And if you combine the remainder, the undiagnosed individuals in that series with our new 15% yield of pathogenic or likely pathogenic variants here, then we estimate around a third of individuals with MPT would get such a variant identified. That's been part of a recommendation in our NHS Genomic Medicine Service testing directory. That's a national guidance for who to test in inherited cancer. It's not in there yet, but it's been put in as a suggestion that we should be using this as a potential criteria. It's worth remembering that most people would have a diagnosis based on other criteria, for example, an early onset breast cancer, but we think it probably represents a useful catch-all when considering who to test. And to go through just at the end, I'm going to go through a couple of interesting points about doing this kind of testing. Of course, it is possible to have more than one constitutional pathogenic variant in a cancer predisposition gene. That's not a new phenomenon, but we've previously tried to promote the term multilocus inherited neoplasia allele syndrome to promote data sharing about these individuals and have an area on the Leiden Open Variant database to share cases. And that's because it's not always very straightforward what the effect of these double variants or MENAS might be. Feasibly, there could be an enhanced effect, so a more severe cancer phenotypes as a result. There may be a little, so they may act independently, so each one occurring as if, or acting as if the other one wasn't there, and that's tends to be the picture when you look at the cases reported in the literature. There could feasibly be a protective effect from synthetic lethality, but that would be very hard to identify clinically or in research studies. And these are just a few examples of the 3 cases from this particular series that we identified. There was an individual with bilateral pheochromocytomas with a MAX mutation, but also a potentially contributory FH mutation, because variants in that gene have been described in pheochromocytoma. The individual on the last slide with the folliculin translocation, well, that family also had a CHEK2 common truncating variant, which it's difficult to see how that contributed to the phenotype, but it's difficult to completely refute it as well. And then there was an individual with colorectal cancer and also breast cancer who had 2 colorectal cancer predisposition genes, but more evidence for the PMS2 being the cause, at least of the colorectal carcinoma in that case. And we can expect to see lots of these cases and are seeing them as more agnostic genetic testing is applied, not just in multiple primaries, but single cancer phenotypes as well. And one area that we're just getting into really with this series is mosaicism, and that's because multiple primary tumors represent a potential opportunity to identify this, because you have 2 tumors that can be sequenced where you might find the same cancer predisposition gene variant, and you'd also have germline, and you can look for absence of that in the germline, and that indicates possible mosaicism. And that's quite important because that has significant implications for the rest of the family and continuing surveillance of the patient. So we have we selected a number of these individuals, and we only had 3 at the time, to try and look for more likely mosaicism. These are individuals who'd had 2 primaries under 50, so a bit younger than the general inclusion criteria, and whom we had 2 tumors available to sequence. Only 3 of those, but we performed gene panel sequencing, which we had to do because the DNA was from formalin fixed paraffin embedded tissue, which is hard to do whole genome sequencing on, but they did have the blood tested. And out of those 3, we identified these 2 individuals, both with bilateral tumors. The first one had a clear cell renal cell carcinoma bilaterally, and the same VHL frameshift mutation in both of those tumors that was not seen in the germline at all, and the variant allele fractions were consistent with heterozygosity, at least in the tumors. And then there was this TP53 nonsense variant as well, in someone with bilateral breast carcinoma, similar picture without the variant being seen in the germline or the blood data at all. And when we looked at the other variants within those tumors, there was relatively little similarity between them, suggesting that they were possibly part of a mosaic picture that had gone on to differentiate as independently arising tumors. So just a few comments then in conclusion. MPT, it's relatively common and can indicate a cancer predisposition syndrome. If you do agnostic genetic testing on this particular phenotype, it does produce an appreciable yield of variants that are assessed as pathogenic or likely pathogenic. And you get a lot of atypical phenotypes here. So many individuals won't have a tumor consistent with a variant in the particular gene. That could be that they're incidental, or it could represent some phenotypic expansion of the gene in question. And you can reveal some interesting phenomena such as structural variation, multiple variants, and possible mosaicism. And just to close, I'd say that the project remains open to recruitment, and we can and have accepted samples from non-UK participants, with the caveat that a DNA sample export is required. Okay, so I think the next one's just an acknowledgement slide. So thank you again, and look forward to the discussion.